Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Sukhpreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Hello and welcome to today's episode of the MenopauseWize podcast on sexual health, midlife, and South Asian women, breaking the silence, where I'm joined by Dr. Sadaf Lodhi. Dr. Lodhi is a board-certified obstetrician and gynecologist who has been practicing in New York for over 20 years. Dr. Lodhi's work is centered around empowering and educating women with a special focus on sexual health, menopausal care, and intimacy coaching. She currently runs a concierge medical practice serving patients in New York and also provides telehealth care to women in Michigan. While she supports women across all aspects of female health, her clinical passion lies in helping women navigate midlife, sexuality, and hormonal transitions with confidence and clarity. Beyond her clinical practice, Dr. Lodhi is also the host of the Muslim Sex Podcast, where she explores conversations around intimacy and women's health in culturally nuanced spaces. You can also find her on Instagram at Dr. Sadaf OBGYN, where she continues to break stigma and educate women about sexual and menopausal health. So, thank you so much for joining me today, Dr. Lodhi, for this very crucial conversation around sexual health, menopause, midlife, and South Asian women. Because when we look at sexual health and midlife, that conversation is so muted today. And once we layer in the cultural context of South Asian women, that conversation is just practically non-existent. So thank you so much for breaking the silence with me today. So looking at it very broadly, could you explain to our audience what really goes on during midlife, the perimenopause, postmenopause, with regards to biology and physiology and hormones, and how that impacts the anatomy, the vulva, the tissues, the vagina, the urinary tract, so that we have a basic understanding of what's going on during this time?
Sure, of course. And thank you so much for having me on. So, menopause is the time period in a woman's life when she has no period for a whole year, right? The time before that is considered perimenopause. And at that time, we have estrogen that is fluctuating. We have progesterone that is starting to go down. We have testosterone that is starting to go down. We know that the ovary produces three hormones, estrogen, progesterone, and testosterone. And when menopause occurs, we don't get those hormones anymore. We don't have the ovary producing those hormones. We do get a little bit of testosterone from the adrenal glands, but pretty much the estrogen and progesterone are all gone. Postmenopause is the time after menopause. So menopause is that 1 day event, and then postmenopause is all the time thereafter, and it continues until we die. So we're in postmenopause forever. And so oftentimes I'll have patients say to me, "Oh, a menopause, I went through that a long time ago. I'm not in it." You probably hear that all the time too. And I'm like, "Oh no, we are in postmenopause forever until we die." I think that's something that people need to understand as well. Perimenopause, we know, varies based on ethnicity. And that's from the SWAN study that was started, I believe, in 1994. And it was a multi-center study, and it looked at women through midlife. And what they noted was that, based on their observations, was that African American women tended to go through perimenopause for about 10 years, Hispanic women for about 8.9 years, Caucasian women for 7 years, and Asian women for 5 years. I always sit there and think, what happened to South Asian women? I don't mention South Asian women. And so I did a little bit of research, and what I saw was about 8 to 9 years. What have you seen?
I haven't seen many studies, to be honest, but
Yeah.
I have come across a few sporadic studies on the age at menopause. I haven't really come across anything which really explains what goes on with us during perimenopause.
Right.
But yeah, the question of, oh, what happened to the South Asian bit, which sometimes I went for a DEXA scan in Vancouver a couple of years ago, and I had multiple ethnicities that I could tick off, and I couldn't really find South Asian anywhere. But yeah.
Nope, it's not there. Yeah, and I notice also in some of the research that I've done in the past is that South Asians tend to go through menopause earlier. It's I think like in India and in Pakistan, they noted in their late 40s. So the mean age for somebody in the US to go through it is around 51, 52. But the research that I saw for South Asians was around like 47, 48, 49. So that seemed to be a little bit earlier. Your question about what happens in perimenopause was, since we have the estrogen fluctuating, we get a lot of women will get the hot flashes, the night sweats, the joint pain, the dry eyes, dry mouth, pain with sex, decreased lubrication, pain in the joints, pain in the hips, heart palpitations, brain fog, weight gain. There's so many symptoms, right, that happen to us. And I really feel, and I started to write a paper on this, is that I feel like perimenopause, I don't know, I know you're a gynecologist as well. And so oftentimes as gynecologists, we say that pregnancy is a window into the future of a mother. And I feel like perimenopause is the same. I feel like the cardiometabolic changes that happen during this time, if they're not taken care of, can really lead to chronic diseases in the future, right? So perimenopause is really the time for somebody to take hold of their health so that they don't have those chronic conditions in the future. For example, like heart disease or increased cholesterol, or for example, diabetes, which is huge in the South Asian community, and also high blood pressure, right? So if we start to see those things starting to happen in perimenopause, this is the time for us to really take action and make lifestyle changes that are going to lead to hopefully a healthier future. And in terms of your other question, what happens to the vulva and the vagina? As we know that we have these fluctuating estrogen levels. And so we start to notice, a lot of women will start to notice decreased lubrication. They'll start to notice pain with sex. They'll start to notice perhaps decreased sensation, or that arousal takes that much longer, or that they're not able to orgasm as easy as they once were. And that has a lot to do with, of course, our hormones. As our hormones start to decline, we start to see that the testosterone also starts to go down. So then libido is actually one of the, when they did this study, so there was a study called the Preside study, and they looked at female sexual dysfunction in midlife. And they asked, it was a questionnaire, and it was, I believe it was over like 45,000 women. It was done here in the US. And what they looked at, they asked women, what is your biggest concern in midlife in regard to sexuality? And so the number one sexual dysfunction that came up was actually libido. And about 12% of women actually noted distress with their decline in libido. So we know that libido is huge in terms of what starts to happen in perimenopause, and it starts to decline, and that women are really concerned about this, right? It starts to affect their families, it starts to affect specifically their partners, right? And their partner starts to think that, oh, they're not attracted to me anymore, or there's something going on. And it really is hormonal, right? Mm-hmm. Also, if you have decreased sensation due to the decline in estrogen in the vulvar region, you're not going to experience as much pleasure. And I think that a lot of times what we don't ever focus on, especially in South Asian culture, I don't know if you have seen it with your patients when you were in India, but we definitely don't focus on pleasure, right? That's not something that's really conversation. And I really believe that if somebody is not getting pleasure out of something that they're doing, then they're not really going to want it. And that it'll just become another chore on their list of things to do. And anytime something becomes a chore, it's not really, people don't really want to do it. I know I don't want to clean my house because that's a big chore, right?
Agreed.
Feel that.
But
yeah.
I guess three parts to this. The pain.
Yeah.
P is the libido or desire. And then the third part is pleasure. And if we break it up into three pillars, perhaps it'll be a little simpler for our audience to understand. So if we can address pain first, because that can be the main reason why there is no pleasure or there is no desire. And how often do you see women in your practice complain about painful intercourse? Do they actually come to you with that symptom, Or is it that you have to probe them it's by the way, or is it the primary symptom they're presenting with, especially keeping the South Asian woman in mind?
That's a great question. And that is never what is brought up. Usually, what is brought up is the hot flashes, the night sweats, the other things that often come up. And the pain, they don't really talk about until you do a vulvar exam. So then you start doing the exam. And honestly, I just started doing I feel like the proper exam when I learned it through ISHWA. ISHWA stands for the International Society for the Study of Women's Sexual Health, and they talk about really examining the vulva and doing that Q-tip test and seeing, do you have pain and things like that. And it's funny because nobody ever says that they're having pain with sex, right? Or they rarely bring it up. And then when you start doing that exam, the Q-tip test, and you start touching the vestibule, right? So the entry into the vagina, and you start touching that with the Q-tip, and all of a sudden it's, ow, that hurts, ow, that hurts. Oh my God, what are you doing? And this is so painful. And that they've been having pain with penetration this whole time, but it was something that they felt was normal, or that something that just happens, right, as you get older. And they didn't know that this is actually something that can be fixed. So I think that definitely comes up later. And I agree with you. I think that once you start to have pain, you're not going to want sex, or at least you'll try to avoid it. Or what some women do that I've seen is that they'll just push through the pain. Even though they have pain, they feel like it's like this duty that they have to have sex with their partner. And so they'll just push through it and just deal with it. Or they'll hold their breath and they'll be like, wow, I've been having pain like this for so long. I didn't know that this wasn't normal. And then what happens is that those muscles around the vagina tighten up. Then all of a sudden women start to get secondary vaginismus. And we know a lot of people in the South Asian culture deal with vaginismus to begin with as a primary problem. But sometimes people that never had pain with sex or never had any issues can start to develop it, because now as we're getting older and those hormones are starting to drop off, and we know the vestibule is very sensitive to estrogen and testosterone. And so as those hormones start to go lower, that area, that vestibule, is going to start to become painful. And women will start to have pain with penetration. And then when they start to anticipate that pain, that's when that vaginismus starts, right? Because we know that vaginismus happens anytime there's fear of penetration or that it's going to hurt, right? It could be with a tampon, it could be with a pelvic exam, it could be with intimacy, it could be with sexual penetration. And we know that when that starts to happen, then, secondary vaginismus can start to happen. So I think all of those things, right, start to happen in the beginning when these hormones start to go down and there's changes in the anatomy and changes in the vulva, that we have what's called hormonally mediated vestibulodynia. And there's pain with intercourse once those hormone levels start to go down. And then, of course, there's also decreased lubrication that happens as a result of the decline in estrogen. So to answer your question, no, hardly anyone comes in with the problem that they're having pain with sex. It's usually once you start peeling back the layers of everything that's going on and you start doing the exam is when you actually start to see that they've been having this pain for so long, but just thought that it was normal or didn't have anyone to talk to it about.
Thank you for explaining that and explaining all the layers that are involved. So it's not just, it's just dryness, but then that dryness leads to the anticipation of pain, vaginismus, and so on and so forth. And how receptive are these women, especially South Asian women, when they are offered treatment options, let's say low-dose vaginal estrogen, the use of pelvic floor physiotherapy? How receptive are they as compared to their Western counterparts?
Yeah, I think that, it all boils down to education, right? I think that once you are able to explain to a woman that she doesn't need to have pain, that this is not normal, this is not just a matter of aging and she just has to deal with it, that there are actual solutions, I feel that people are very receptive and they don't want to really experience pain. They don't want to have that pain, right? And so if you can do something to help them get rid of that pain, I think that is really important. And I feel like they're really receptive. I think that the problem comes in is if you don't explain, if you don't take the time. And because I'm actually really lucky because my practice is concierge, so I am able to spend like 90 minutes with a patient. And I think that's where the difference comes in, because if you were in a regular GYN office and they have 30 patients waiting outside, they don't have the time to sit there and talk to a patient and tell them exactly what they need and why they need it and why this is important, and to do all that education that they would need to get the patient to understand why they need to do this, right? If you just throw something at somebody and say, okay, here are some creams, here's some vaginal estrogen, I also think you need to do physical therapy, they're just going to walk away. One, they may get overwhelmed and just decide to be like, forget it. This is not an important thing in my life. I don't care. I don't want it. I don't need it. Or two, they just may not understand the significance of it and understand that they can actually be pain-free if they were to use these medications, if they were to go for pelvic floor physical therapy. So I think really the key thing is the education. And when you can educate somebody, because I think everyone wants to be pain-free, right? I don't think there's anyone that enjoys pain, not intentionally. And I think that if you're able to give them the education, I think they're really receptive. And same thing with their counterparts, right, of other ethnicities. I think it all boils down to the education and explaining why they need a certain thing, and just explaining about the hormones and how the hormones go down. It's not anything that they did. I think a lot of times South Asian women will also take it upon themselves and blame themselves, like there's something wrong with them, or maybe they did something, or they'll think of something like way in the past, and they'll be like, oh yeah, when I was like, no, it's not that. It's what's happening right now in your hormone. That's why it's happening.
Do you think they also associate many things with aging much sooner than the Western counterparts? Like,
yes,
I'm
absolutely.
getting old. I'm
Yeah.
getting old. You're 50. You're not getting old. Just that.
All the time, all the time. I'm sure you see that too. They're like, oh, I'm just so old now, and this is just what happens. And they act like they're like 100 years old.
Exactly,
You're like,
exactly.
no, really, you're not that old.
Yeah.
So
You know the terminology buddhi?
yes.
Yes. So now I've become buddhi. No, not yet, not yet. So yeah, you're so right. Just the thought that I think sometimes when I'm sure you see it in your practice too, when you tell a woman you can actually get rid of this pain, there's that look on her face of disbelief, like, really, you can? It's quite rewarding, isn't it?
Yeah, absolutely.
Yeah. And you're so right about the education bit, because also, do you see if you're not educating well enough, you're right about spending time with a woman explaining it, because even if one has written that prescription, discontinuation of treatment can happen so easily.
Yes.
Now that the black box warning is gone, okay, that's not there to frighten them, but just how to use that applicator,
Right.
or the fact that if you discontinue it, it could come back, or there is need for treatment,
Yeah.
communication and education. What about, do you see any difference in, and I see this often when I'm prescribing MHT for women, if I tell them, especially Indian women, because most of my work is there, and if I tell them this is for prevention of osteoporosis, they're happy to take it. But if I tell them, hey, could give you symptom relief, so there's this burden, this feeling of guilt of wanting to, should I? Like, is it okay to take it for symptoms? So do you feel like vaginal estrogen, there is a difference when you say you can use it for recurrent UTI versus the use for pain-free sex?
Yeah, absolutely. I think sex is seen as, you and I talked a little bit about this offline, is that I feel that sex in a lot of South Asian cultures, right, is seen as wrong, dirty, shameful. And it's not something that is seen as a priority. It's almost seen as like a luxury or something that you just do to get children. But it's not something that is seen as, at least when I was growing up, or I didn't really have this kind of sense that it was seen as something that you could do just to do for enjoyment, right? That there was like a role for sex and that was why you did it. Otherwise, you don't talk about it. It's not something that is, if that's the problem, that's like a little bit over the top, right? Like it's unnecessary. Like it's, as we get older, oh, maybe you don't need sex anymore. So if that is the reason why you're going to give me the medication, then I don't want it, right? But if you're going to give it to me for a health reason, and I will say that I've had this conversation actually not just with our South Asian women, but also with different ethnicities that I see in my office. And they'll tell me, oh, you're giving me vaginal estrogen to improve lubrication. Oh, I don't need it. I don't need it for that because I'm not sexually active, or I'm a widow, or I'm divorced, or I'm not in a relationship. So I don't need that for that. And I'll be like, no. I'm like, listen, it's not just for sex. I'm like, it is for to reduce that. I said, I always ask the women that are in, perimenopause or menopause, and I'll say, do you feel like you have to go pee all the time? They're like, oh my God, yes. Oh my God, if I don't go to the bathroom, I'll pee my pants and this has happened. And it's all, I'm like, okay, so this is why we give the vaginal estrogen. And I'll say, have you had UTIs? And this one woman recently that I was talking to, she's like, yes, I've had 8 in the last year. I said, okay, so this is for that. I said, it's not necessarily, I'm like, that's great if you're sexually active, because it'll help with that. It'll decrease the pain and it'll increase lubrication, all that stuff. I go, but don't think of it as that is the only reason I'm giving this to you. I'm giving it to you for also to prevent these recurrent UTIs, to get rid of your overactive bladder, to decrease that dryness that you're having, that discomfort, right? So it does all of these things. But if you tell patients that it's just for sex or just for to increase it so that they don't have pain with sex, they'll definitely say, oh, I don't need that because I'm not sexually active.
I guess at some level, we just taught to struggle quietly with these symptoms. If painful sex, that is physical pain, does not inspire or motivate a woman to seek help, then the next step, libido or desire, how do you see women perceive that, or do they even initiate that conversation in the office?
South Asian women, I have never had a South Asian woman tell me that she's had decreased libido. I think that if it's like a friend or something like that, somewhere where they feel a really close connection to you, I think perhaps they'll say, but I will say that of all my conversations with South Asian women, no one has ever, at least to me, brought up the topic of decreased libido. I get it all the time with women of other ethnicities, right? Like with my Caucasian patients, with African American patients, with other Hispanic women, with other ethnicities. I will absolutely, they bring it up. That's something that's concerning to them. They're very concerned, distraught by it. But I have yet to have a South Asian woman come to me and say she has decreased libido. And I don't know, I wonder if it's probably in my head, that it's cultural, right? Like it's culturally ingrained. Like women are not supposed to want sex, right? At least South Asian women, at least from what I see. And that maybe there's almost a stigma or a taboo for a South Asian woman saying that she has decreased libido and that she wants the same sex that she used to have, or the same desire that she wanted before all these hormonal shifts happen. And I haven't had any woman come to me, South Asian, that I can think of recently or ever, to be honest, saying to me, my libido is low and it's really, it's distressing to me and I want treatment for it. Have you seen that in India when you go and you practice?
I'm beginning to see it.
Oh, okay.
It's not usually the primary reason they're seeking help, but a few women will bring it forth. I nudge women a lot. I have a little vibrator on my table to put it out there and say, hey, the conversation's on the table. But I am beginning to see women talk about it. But 19 out of 20, there would be just that 1 in 20 who actually ask for it, but it's still a fair 5%. I'll take that today. But 95% of women will not bring it up. And very often they will not bring it up. But if I question them, the answer would be anything from, oh, it's a black hole, versus is there a negative scale, or it's non-existent, or I feel like I'm living with my brother. There's a range of it's amazing what I get to learn. Yeah, you must be also then learning so much from what women have to say in the clinic. But the minute there is the question of, do you like to do something about it? And how do the women who visit your clinic, how do they perceive that question? Would you like to do something about it?
They are very receptive. They definitely, because especially those women that come to me that have decreased libido definitely with distress. There are some women, I will say that it was never a big part of their marriage. And in fact, I just had this the other day. I was seeing a patient in my office for the first time, And I asked her, I said, how often, this is just asking about sexual history and all of this. Are you sexually active? She says occasionally. And this was a Caucasian woman. And I said, okay, so how often would you say you have sex? And she said about once every 3 to 4 months. And I said, oh, okay. I said, does that bother you? Is that something that does that matter to you? And she said, not really. She said, that's how all, throughout, and she's been married now for 20 years. And she said, that's what our marriage has been like the whole time. And it was never a big part of our marriage. And so for her, libido she said, it's definitely gone down. But because it's not a big thing in her relationship, it doesn't bother her. And she doesn't really care if she does something about it or not. I think more for herself, she wants to know, she wanted to have her testosterone drawn just to see where that was at, just for her own sake, but not really for the relationship. But there are definitely women that come in and say, my libido is so low and it is absolutely affecting my relationship and I want to do something about it. What is it? What can I do? And so we talk about, I do the biopsychosocial aspect of sexual medicine that we always do with any type of dysfunction, right? So I look at biology, what's going on, and that's what you mentioned about if they're having pain, they're not really going to want sex. And then we look at psychologically what's going on with them, if do they have anxiety or depression? Also biologically, right? If they are side effects of medications, right? So we go over their medications, if they're on SSRIs, if they're on antidepressants, if they're on some type of calcium channel blockers, maybe some diabetic meds, birth control pills, right? We all know that they can decrease libido. So we take a look at all of that. And sometimes when we do the vulvar exam, we'll see that the patient has perhaps lichen sclerosis, that she has some scarring over the clitoris that's affecting her orgasm, or that the opening, the introitus, has become so narrow because of the lichen sclerosis that now sex is really painful, right? So that's why for me, it's so important to do this physical exam when I'm talking to patients about their libido. And we already talked about vestibulodynia and we talked about vaginismus. And then I go to the social aspect of it, right? And then I look at what could be affecting her libido socially. Was she raised in a sex negative community? Was she told that sex was always wrong, shameful, and dirty? And so she feels she can't get those thoughts out of her head when she's having sex. Is she a single mom? Is she in a very stressful relationship? Is she in a relationship where she doesn't feel safe? Is she in a relationship where there are problems in the marriage, maybe with the in-laws or something like that? We know sometimes in South Asian communities that can be a big problem, the in-laws. Right. And not just South Asian, but all communities. But I feel like because you watch those Pakistani dramas, there's always some drama with the in-laws. So that's why. But anyways. So, right. So then you look at the social aspect of it as well. You look at, is she working a job and then she's taking care of the kids and she's helping with homework. And so now sex just becomes one more thing on her list of things to do and it becomes a chore. And so then she doesn't want it. So I always make sure that I go over all of those things with women. And that's why those appointments take so long, because you have to go through all of those categories to see where that libido has been affected and what you can do. And of course, we have different, here in the US, we have 3 different therapies that we use for a decreased libido. We use testosterone. There's also flibanserin, Addyi, and there's also bremelanotide or Vyleesi. So those are the 3 medications. Testosterone is used off-label for hypoactive sexual desire disorder, but Vyleesi and Addyi have been approved through the FDA for low desire. And we do have some medications that we can use, but we always want to make sure that we address all levels of what could be affecting that libido.
Thank you for sharing that. And right now we have these options available in North America, which unfortunately we still don't have in many other countries, but hopefully we'll have them soon, except for testosterone, which is available. But how open are women in accepting these treatment options? Do they welcome those options, or are they a little resistant, thinking of them as what they call unnatural and unphysiological?
Yeah, so I think that definitely those women that are suffering with low libido and that's causing them distress are absolutely willing to do something about it, because it's affecting their relationship, it's affecting them, it makes them feel like something is off. And here in the US right now, I feel like there's been a really big push for testosterone. And we know that it's a really important hormone as we get older and as we lose the testosterone because of menopause, even though we do get a little bit from the adrenals. I think that women are really receptive to using testosterone. And at least in my practice, women are very receptive to using testosterone. They're also, once you explain, again, it goes back to just education. And so once you explain how, let's say, Addyi works or Vyleesi works, it works at the level of the neurotransmitters in the brain and it works differently than testosterone, I think that women are really receptive because it's causing distress in their relationship and it is really affecting them. And so they want to do something about it. And because they're motivated to do something about it, then, they're definitely open to different types of treatments.
And do you think the impact of this reduced libido is differently perceived in long-term marriages or relationships among South Asian couples as compared to the Western counterparts? The reason I'm asking this is, again, such a cultural layer to this with respect to marriages are just supposed to be forever and not separating out or accepting that intimacy and physical intimacy is a crucial part of the marriage, or it's not important in our marriage. But what are your thoughts about this?
Yeah, I think that it's so funny, right? I feel like I think that more and more people like South Asians are starting to talk more about intimacy and relationships, but I feel like it is a taboo topic, right? And I think that so many people are not comfortable talking about it. And when they don't talk about it, they don't really address it. And I think that it's like a hidden, almost like a pain or a hidden problem that they don't want to talk about. And I think that very few South Asians that I know or that are my patients will even talk about the decreased libido. It's just not, I really feel like, again, what we talked about before, I just feel like it's seen as almost something that's not really necessary, right? Like sex, like it's just that you have it to have children, but outside of that, it's not, if it's not working or if you don't have sex, like it doesn't matter. You're still in a good relationship. Like you're here. Patients will tell me like if they try to bring that topic up with their parents or something like that, their parents will be like, oh, it's not, it doesn't matter. Don't worry about that. It's not an important part of your relationship. Is he paying the bills? Is he taking care of you? Is your house, is he a good father? Yeah, that's all you need, right? It doesn't matter if you're not having sex. Who cares? It's not a big deal. What do you think? What do you see?
No, absolutely. I completely agree. It's considered as an extra.
Yeah.
It's the extra. If you have it, it's great. If you don't have it, it's okay. It doesn't really make a difference to your health. So like the whole sexual health is health. They call it sexual health. So it is part of health. So I think that it's just used, the term is used pretty like loosely and people say sexual health, but they don't really believe it is health. Just like
Correct.
mental health, it took the world a while to actually not just use mental health as a pair of words that go together, but in its true meaning, it is a part of health. And I think that perception will take a little while, especially in South Asia, to be properly integrated into a health structure.
I think that is such a good, like such a really important point that you just mentioned, is that even though we call it health, people don't see it as health, right? Like you said, it's like an extra, it's just something like on the side that if it's there, it's fine. It's not a big deal. As long as everything else is being met, that shouldn't really be your concern. You shouldn't worry about it. If it doesn't exist, who cares? And then you'll hear like some people say that their parents will be like, it was never a big thing in my relationship, so it's not a big deal. Look, you're fine. You turned out fine.
No, absolutely. And that whole good girl, bad girl thing.
Yeah. Like good girls really don't want it. It's not, absolutely. The perception of someone that wants sex, right? Yeah.
Like, really? Do you want sex? Oh my God, you must be a bad girl. Anyway, let's get to the most uncomfortable part of the conversation now. Orgasm and pleasure. And if women aren't talking about their discomfort, they're not talking about their desire.
Yeah.
Are they really talking about pleasure?
Yeah, no. That was quick. I'm like, forget it. Orgasm, what the heck? Not only just South Asians, but I feel like a lot of women, I was surprised at how many women have come to me and told me that they've never experienced an orgasm, or that they faked it, or that they're not really sure, how to get it and how do you get it. And sometimes when they focus really hard on it, it's even harder, right? Because when you focus so much on something, it's not going to happen. And that's where I actually love the modalities of sensate focus and mindfulness. There's a book called Better Sex Through Mindfulness with actually Lori Brado, right?
Lori Brado.
Yep, she's in British Columbia. And Sensate Focus with Linda Weiner. And I love the idea because it's more about being present in the moment, right? And just enjoying what you do. And it's more about pleasure. It's not about an end goal or an end result, especially with Sensate Focus and really both of them. Because with Sensate Focus, right, I don't know if you're familiar with that modality, but it's a modality used by sex therapists. And it is really about, and I love this for people that have never had sex before, and also for people that are in a sexless marriage and are trying to reintroduce sex in their relationship. And what it does, it's a stepwise process. And it really talks about about touch. And that's why it's called Sensate Focus, because it's about touch, it's about taste, texture, pressure, and really feeling somebody's hand, or feeling even your own body for your own sake, not for anyone else's pleasure. And it's almost like, the way that I describe it to people, it's almost as if you're like an alien coming down, like a human person, and you start to touch their hand and you see what it feels like, right? What it feels like for you, not for them. And you're just feeling the texture of the body, and what does that feel like to you? And then also, it's a stepwise process. So you do it with clothes on, then with clothes off, then in the erogenous areas, then the very end can be penetrative sex. But it's not like, orgasm is not the goal. The goal is just pleasure. And the reason why I like it for somebody that's never had sex before is that there's no pressure, right? I think that all I can talk about is really like, let's say in Muslim communities, right? We're not supposed to have sex outside of marriage. So once you get married, so you've never had sex, then all of a sudden you get married. Then all of a sudden, the next day, people are wondering when you're going to have kids. You're like, I don't even know if they've even consummated the wedding. What the heck? Because nobody's ever really talked to them about sex. And people think that it's just really easy. And once you get married, then all of a sudden you're going to be having like this crazy sex and you're going to have kids. But it doesn't happen that way. Yeah. And for a lot of women that have been taught that sex is wrong, dirty, shameful, all this stuff, end up having vaginismus and they can't even consummate the wedding. I had somebody call me from Michigan who had been married for 8 years, if you can believe that, and has never consummated her wedding. Mm-hmm. She's in so much distress. I can't believe that she's still married to this guy. Either he's really patient or I don't know, but they're still together. And she doesn't know what to do. And she can't, she's having so much fear with this penetration. And then I told her she wanted to come to me, whatever, but I told her that she needed, I'm not in Michigan, I'm in New York, but my practice is in New York, but I do telehealth for Michigan. But I told her that it's a multi-specialty treatment plan that we do for somebody that has vaginismus, right? You got to see a sex med doctor, you got to see a pelvic floor therapist, and you got to see a sex therapist. And all three people need to communicate with each other to help you in your plan. And especially if you have such really bad vaginismus, you may need pelvic floor Botox to help relax pelvic floor muscles, along with physical pelvic floor therapy to help relax those muscles. So I think that a lot of women that we aren't even talking about what happens, right, in marriage and what happens with sex. And because it's been taboo for so long that so many women have that idea in their head that it's wrong and they can't talk about it, and then they don't have anyone to discuss this issue with. So I think that the Sensate Focus really breaks it down, and you can look it up. It's a modality. So many different, like Cornell has one, so many different institutions have Sensate Focus, and they have the stepwise approach, and you can read it and you can work on it. And I think it's great as a couple that are not sure what to do. It lists it out literally for you. And then also with Better Sex Through Mindfulness. Mindfulness, how does that work? She teaches you, Lori Brado teaches you in her book, like how to just focus on, be present in the moment without judgment. And she talks about so many women, and she actually talks about her paper that she and Rosemary Basson did about women. They had a group of women that had come in with the chief complaint of decreased libido. And what they did is they put them in a cohort group of 90-minute sessions for 6 months. And I believe they met, I want to say, I don't know if it was once a week or once a month. I can't remember the frequency, but all they did was mindfulness. And what they noticed was that at the end, women had increased lubrication, increase in desire, and decreased pain, all because they focused on mindfulness during sex, right? So there was an increase in pleasure, an increase in libido, even without medications. And that's why when I talk to patients about libido, it's not just about drugs, what can we do, or things like that, but it's also about incorporating mindfulness in that relationship, in when they're being intimate with their partner, so that they can experience pleasure. And it's not all about just the orgasm.
Absolutely. Absolutely. And we know that libido, there's only 50% of women who actually report their libido improvement with testosterone. So there is something else going on as well with regards to what's going on in their relationship and the way they perceive it. And more importantly, I feel if women's symptoms aren't taken care of, as you mentioned, the whole biopsychosocial aspects of libido. If I'm so exhausted looking after my house and my kids and my job and getting hot flashes and not sleeping, who wants
Right.
to have sex then?
Correct.
So,
Exactly.
yeah.
Exactly. And we know that the biggest sexual organ is the brain, right? So if we are, and some women, when they're being intimate with their partner, are not really in the moment. They're spectating, right? They're almost like an out of body experiencing, like they're looking at themselves. Women have a lot of issues with body image, right? So, as they've gotten older, they've gained weight, or now they have these new roles, and now they're thinking like, wow, I don't even look good. Look at this. I'm so fat, blah, blah, blah. And when you are like, not even in the moment of what it is that you are doing, you're definitely not going to experience pleasure. It's not going to be something that you enjoy doing because you're not even present at that time.
Absolutely. Absolutely. How do you think the next generation of South Asian women will take this forward?
I
Do
don't
you
think they're
think
going to
they?
take it.
I'm so
I
happy
don't
to
think,
hear that.
yeah, I don't think they're going to stand for it. I think that with our parents, there was just a lot of cultural conditioning. There were certain things that you talked about, certain things you didn't talk about. And it's so funny. I remember saying to my mom, specifically talking about sexual health, but also talking about like menopause and things like that. And I said to my mom, I said, how come you never told me about any of this stuff? And she said, and I think this was such a fantastic response, and it really had me thinking. She said, no one talked to me about it. How could I talk to you about it? So that talks about generations of women that didn't know about, let's say, sexual health, or maybe if they knew, maybe their families weren't comfortable talking about it, right? About pleasure or about menopause or any of those things, right? They just went through life, but they didn't I feel like they're just so focused on their children, right? You probably see that too, like South Asians are focused on their children and their children doing well and just really wanting them to be happy, that they forget themselves as women, as people. And that they deserve pleasure, they deserve to be happy, they deserve all of the good things that they want for their children. And so I feel like the next generation of South Asians, right, perhaps starting with us, is that they're not going to deal with it, right? They're not just going to let things happen and just be like, oh, this is the way things are. No, because with the advent of social media and so much information out there, I feel like people are now becoming so knowledgeable about pleasure and about sexual health and about menopause and perimenopause and all this, that they're not going to sit back and just be like, oh, this is just something that happens and I'm just going to let it happen. No, they're going to be like, no, I know there's treatments. I want the treatments. I want to be treated. I want to feel like myself again.
Absolutely, absolutely, and then it's so optimistic,
Yeah.
and I think we need to remain optimistic for women. We're just waking up, and it's going to just go upward from here.
Yeah.
To close, if you could offer three pieces of advice for South Asian women in particular with regards to sexual health, what would they be?
Yeah. I think that's great. I would say number one, sex is not supposed to be painful. If it is, get it checked out, figure out what's going on. There has to be a reason. Sex should not be painful. Two, if you have decreased libido, there is no shame in having a high libido. I think that women get shamed a lot. And then when we think about like high or low, what is it in reference to? Are we comparing to their husbands? Are we comparing to their friends? Who's to say who has a high libido, who has a low libido? And I think that there should be no shame in if a woman has, quote unquote, a high libido, there's no shame in that. Good for her. I'm glad she has a high libido. She should. If she wants it, she should. And she should celebrate that. And I think 3 is knowing that there is treatment for vaginismus, that you don't have to suffer, right? If you haven't been able to consummate your wedding and that is really important to you, then there are treatments out there and that you can get help. And so don't sit back and let things happen to you. Make them happen for you and know that you can always get some help.
Oh, wonderful. Those are clearly impactful takeaways from our discussion today. And thank you so much, Dr. Lodhi, for having this conversation, for unpacking not just the physiology of menopause, but the cultural layers that shape the experience of South Asian women about sexual health. I think it's so important that conversations like these truly break the silence for these women and they're able to have a healthy sexual life, or however fulfilling it may be, whatever the version may be for that woman, but to be able to explore it and be happy and content with it. So thank you so much for this.
You're welcome. And thank you. And one last thing that I want to say to South Asian women is that give yourself permission, right? Don't wait for that permission. You may never get it from anyone else, but give yourself that permission to experience pleasure. Yeah.
Absolutely. Love that. All right. Okay. Thank you.
Thank you. Thanks for having me on.
Thanks again for tuning in to MenopauseWize. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewize.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.